Okay, so good afternoon, everyone. So it's a great pleasure for me to introduce friend and colleague Dr. Brian Vezi from Durban, South Africa. And Brian's an EP there, well known in SA. And he's going to show some interesting EGMs, Brian, some wide complex to narrow complex tachycardia. So over to you.
Yes. No, thank you very much. Since it's my first time here, I'd like to thank Ashley and the rest of AFRA for inviting me. Partly it's my fault. I haven't been part of this. Number two, I don't know the format of this meeting, but what I always like doing is interacting with people during presentation, not necessarily to wait till the end of the presentation. And obviously, because there's a hierarchy in this meeting, it would be better for the fellows to be the ones up. If I ask a question, maybe it should go to the fellows first, and I encourage them to ask me questions. So Ashley, in the meantime, you're probably going to guide me as how to do this. But I'm going to present this as unknown ECG tracings, like you picked it up from the floor, and we go with it. Is that fine?
Yeah, sounds good. Right.
Okay. So this is the first EGM that we will discuss. Is there a fellow who would like, I know I've got another 50 minutes for this meeting. So is there a fellow available to have a look at these EGMs and tell us what's going on? Anyone, any takers, but preferably the fellows.
Hamza Zainuddin. Hamza.
Hamza, you're on the spot.
Yes, I am, but I didn't.
You haven't been able to see.
I didn't follow the case from the beginning.
Okay, Iman Samir, please answer
Yes,
this.
Dr. Marbut.
Yes, please. Iman is the third-year fellow in Egypt. Please, Iman, look at the tracing and explain what you are seeing.
Okay.
Yeah, so
we're just seeing lead 3 and AVF and D1 service ECG, the first 3 leads. Yes.
Iman? Yes. So my approach is, so don't ever give a diagnosis when you look at the EGMs. I like the way you're starting. You describe what you see, and eventually after your discussion, you see what fits what you describe. So yeah, go ahead. Sorry to interject.
Okay, thank you. We're seeing lead 3, then AVF, then lead V1. Then we're looking to the I don't see it, right atrium distal.
It is AVL, Iman.
Okay, I'm
the
not.
second lead
Can
is
you see my
AVL.
arrow? That's HRA.
Okay, it's lead 3 and AVL, then V1. Then right atrial lead.
Yes.
3.
Okay.
AVL,
AVL
then V1.
V1. And then this is HRA. This is his electrogram. I arrange my coronary from proximal to distal.
Yes.
And the very last one is RV EGMs. So just be careful. Yes. I know different labs do it differently. This is a coronary sinus prox. This is a distal coronary sinus.
Yes.
You can go ahead.
And RV, the last one. Okay.
Yes, this is RV.
Okay. And the first one, intracardiac. I don't see what's written here. It's ablation
bundle. Right. This is right atrium.
This is right
atrium. Okay, right atrium. Then his. Okay, with his potential on it. Okay.
Yeah, that's his potential.
Okay, so the third, the left side of the screen. So in left bundle branch block, like morphology of tachycardia. Then on the right side. Okay, with his potential and coronary sinus proximal preceding all the signals. So we may be seeing
Yeah,
Normal
so
conduction. Oh,
so
okay.
so you described the
Yes,
first.
we have a superior axis and left bundle branch block,
Mm-hmm.
tachycardia.
Mm-hmm.
Look at the His
Then
catheter, ya Iman, and you will discover what is different between the left
yes,
bundle branch block tachycardia and the narrow complex tachycardia. Look
yes,
at the narrow complex first and make diagnosis, and then go back to the left bundle. This makes it easier.
yes. On the right side, the his timing on time, and on the left side, the his slightly later on, so it may be a Mahaim pathway.
Okay, may I suggest something? So most of us don't like discussing things that you are highly unlikely to see. So I think your first response should be common things. Of course, if they fit. Try not to go for the rare things just because we're showing these EGMs. Why would you say this looks like Mahaim?
Of
Which part of
left
this
bundle branch,
EGM, which part of this EGM look like Mahaim to you?
which his deflection inside slightly later on,
Okay.
or tachycardia have his potential inside, so
Yeah. All right. So the first 5 beats are wide complex tachycardia with the left bundle branch morphology and probably more leftward axis. So that axis doesn't really help us, right? Because it's left bundle, left axis. And then the other part is what looks like could be simultaneous or almost simultaneous AV tachycardia, right? Narrow complex tachycardia. And all the narrow complexes have his deflection before the QRS. But you'll realize that the first 4 complexes on the left, you cannot see his deflection until the last wide complex. Can you see that his deflection?
yeah, I see it.
Do you think his deflection is before the onset of the QRS or within after the onset of the QRS? Do you think this is left bundle branch or is it something else based on the VA relationship? Anyone else can help here, not help here, but also jump in as long as they are fellows.
Maybe it's apparent left bundle conduction.
So with aberrancy, in this case, left bundle branch block, the fact that in his EGM, in the latter part of it, you can see clear he's. Where is his deflection in aberrancy? Before the QRS or after the QRS?
Before.
Before, right. That's correct. Do you see any his deflection prior to the QRS that is wide in all 5 of these complexes?
No.
So it makes it highly unlikely that this is aberrancy. It could, but less likely, right?
Yes. Could be between right-sided accessory busway and normal sinus rhythm.
Say that. Did you say normal sinus rhythm? Anyone? So this, when you look at it,
Will be right-sided accessory busway alternating with normal conduction through a nodal conduction.
okay. All right. Okay. So what comes to your mind when you see an EGM tracing with wide complex going to narrow complex or narrow complex going to wide complex? What's the most likely thing you're going to see in your cath lab?
With rapid
No.
Or
I'm talking
three.
now about, we've described most of the things. Now we're trying to get to a diagnosis. The first thing that, don't try to make it difficult. So when you see a white complex tachycardia changing into another complex or vice versa, what's the most likely thing that is happening in a day-to-day cath lab? Every once in a month or twice a month, depending how busy you are. Most thing that should come to your mind.
Okay.
Anyone else? Anyone else like to take on that question?
كمل
Ruben, can you answer?
Yes. So
Ruben,
yes, hello, madam.
yeah. What is the comment when you have tachycardia white complex during the lab and at the same time it changes between narrow complex and white complex? What is the commonest cause?
It
Amen.
So Ruben, I can't hear you.
Yes.
Amen. تقوليها bundle branch balancing.
Yes.
Huh?
Bundle branch apparency or common low or accessory busway.
Yeah,
Yes.
common is common.
Yes. So the most likely thing you're going to see is if you see a right bundle branch block goes to narrow, the tachycardia continues, is that you've got an ipsilateral accessory pathway on the part of the bundle branch block, right? So, and then what are the first two things you look at in that change? Cycle length, right?
All right.
Of the right.
Mm-hmm.
So generally,
Maybe orthodromic reentrant tachycardia with left bundle branch block due to the ipsilateral accessory pathway.
so there's going to be, if that's the case, you will see a cycle length change, right?
Right, but here this is no cycle length change.
How do you know that?
No, it's white on the left side. Yes, there is slight cycle length change. Slightly
Okay.
wider on the left side, so cycle length slow slightly on the left side.
Okay. All right. I
that
accept
was
that. So that
obeying
was a cycle length change. Ruben, you saying something?
Yeah, the Kummel's law.
1, 2, 3, 4 squares like here.
So I
1,
said
2,
two
3,
things that you want to look at is the cycle length change in that
No,
single
I think it's four squares on both sides by the calibration down the screen. There is about four.
There's not
1,
much,
2,
right?
3, 4.
Okay.
And
No, that's
okay.
perfect. That's perfect. What's the
Yes.
other thing you want to look at every time there's a perturbation or changes in the cycle length? Thinking that this is maybe SVT. You want to look at atrial activation sequence, right?
Yes.
In this
It's
particular,
it's concentric.
in an
Concentric
ipsilateral,
activation on the left side.
hold on a second. In an ipsilateral accessory pathway moving from white complex to narrow complex, is there a change in atrial activation sequence?
No, in this one, there's no change.
No.
Not in this one, in theory. Should there be a change in atrial activation sequence?
Yes, should be.
Why?
Should be distal to proximal if orthodromic reentrant tachycardia.
Okay, got
It should be distal to proximal
it shouldn't
because
be. Because
if we
remember
have left bundle, so we have the accessory busway on the ipsilateral side. So it will be on the left side, so the activation will be distal to proximal. But here it's proximal to distal.
no, okay, that's I'm gonna answer the question. I'll answer it for you. Should there be an atrial activation sequence change if we're dealing with an ipsilateral accessory pathway that starts off as a left bundle branch, in this case left bundle branch block to Nader complex? The answer is no. The cycle length will change depending how far is it, how far out is it, but the atrial activation sequence shouldn't change, right?
Yes.
Yeah. So it could, if it's decremental, obviously cycle length will change, but not activation sequence. In this case, do you think there's a change from wide complex? Can you see my mouse?
Yes.
Yes.
Is there a change in atrial activation sequence between this beat and that beat? I gave you a sneak preview there.
No.
Is there a change in atrial activation sequence?
No.
No.
Okay, look at the EG. This is A, and look here. This is A. There is a
Yes.
change. Look at the A with this last one. It's the earliest A is in his electrogram.
Yes.
And the earliest A here is in the
It's on the
proximal
coronary sinus.
sinus,
Yes.
right?
Yes.
Yes.
So there is a change in atrial activation sequence, which then makes an ipsilateral left accessory pathway less likely, right?
Yes.
Okay. Now, anyone, including the consultants, if they want to jump in here, let's just concentrate on the red box. Does everyone agree that there is a change in atrial activation sequence from here to here?
I don't
Yes,
agree.
it could be right. It could be right post-receptal accessory pathway.
Oh, no, that's not the question. We like to describe what we see. So here, I'm telling you in the
So
first
so here the
square,
earliest Hess on the Hess, but next beat the earliest Hess on coronary sinus 9 and
yes,
10.
that is correct. So there is a change. All right. And then I've put in the marker here. You can see that the onset of the QRS is before the His deflection. Do you agree with that?
Yes.
So what does this be? Do you think this is aberrancy or something else? The HV is negative, right?
Yes.
What are the two most common causes of a wide complex tachycardia with a negative HV?
VT.
Yes, one. And pre-excited, right? If you like.
Post-receptal accessory pathway, yes. Right
No,
post-receptal accessory pathway. A typical EVNRT could be
hold on, Iman. We describe what we see and we're giving differentials. So one is VT, the other one is pre-excitation. Let's leave it at that, right?
So, Brian, just maybe explain why the HV is negative or different in a VT and a pre-excited tachycardia, just for the juniors.
So if it's pre-excited, right, and you see His deflection, the answer you should be is that pre-excited. Well, that wide complex has got nothing to do with that His deflection, which means dissociation from what is happening in the atrium, or is there consistency between that V and the H? If you see a consistency, it's not really diagnostic, but it probably makes you think it's a pre-excitation, where it goes antegrade down the accessory pathway and retrograde up the His, right? And then you have to now ask yourself, if it's VT, it's usually not always going to be maybe dissociated. You see it sometimes you don't. Now, if I go to beat number 3, that is very sharp, right? I could call that a His, but I don't know, and it's difficult for me to convince you. right? And if this is a his, this HV, this HV is much more negative than that. So it makes, so we know that, I think one thing we can rule out is complex tachycardia. It's not aberrancy. It's not aberrancy. We don't know what it is. We have maybe two differentials, but what we know now that this is not aberrancy because we can clearly see the his on this one. Maybe that's a his as well. Like I said, I cannot convince you, right? But I know for a fact that's a his and it's negative. Therefore, this is not aberrant conduction. Do you agree on that? Hello? Hello?
Yeah.
Yes, yes, yes.
Yes.
I think
We
you
agree
explained
on
it well
that,
there,
yeah.
Brian. Yeah. So it's not aberrancy because the HV interval is different in the narrow complex tachycardia compared to the wide. Whereas if it was aberrancy, the HV interval should be constant in
Yes.
both the wide and the narrow.
And the simple way is that the H must always precede the QRS, no matter how wide it is, generally. I mean, there are nuances where if maybe the HV is long, that's different. But in this case, we've seen two things. A change in atrial activation, that this V is not associated, well, okay, let me retract that. This HV is negative, making aberrancy less likely. Now, I'll put in these two. What do you make of these two circles? That's a V, that's in a coronal sinus prox. That's a V, that's a A. That's a V, that's a A. That's a V, that's a A. What do you think if this was constant?
VT.
Who is that? That's Amadou.
Dr. Muhammad Sami.
Yeah, so it made me think this was
VT.
V, right? It's not, doesn't, it looks like dissociated to me. I didn't put in the numbers deliberately, but it looks like it's not, let me not say dissociated, but there's a change in the VA timing. Ashley, would you agree?
Yeah, the first one looks a bit longer than the second
Yes,
one.
definitely. And now with that VH that is negative, now I'll go back. It must be a fellow. On this second EGM, with the three things we've discussed, a circle, a red bar, a change in atrial activation sequence, what are your thoughts?
Dr. Muhammad Sami. Sami. ايه سامي هربت ايمان
We
بروفا
okay. We can appreciate here another okay. We can appreciate here another change in cycle length and the change in activation pattern. The earliest has on CS910 and H becomes inside or slightly negative, so negative HV during
A wide
narrow
complex.
yes.
So what are your thoughts? What's going through your mind now? Let's just stick maybe with the first 5 beats. Mahaim. Why Mahaim?
The pattern from the service ECG and the negative HV interval during tachycardia.
Have you seen a Mahaim case in your lab?
Yes. Or
How
yes.
many times? How many Mahaims have you seen?
many Mahaims. We can get 2 Mahaims in 1 week. In Egypt, we have many Mahaim fibers, yes.
Yeah, so that's not the pattern throughout the world. So you need to be careful about that. Okay, The Maheim is a decremental accelerated pathway, almost always on the right side, right?
Yes.
But it's still an accelerated pathway, which means that there are certain rules that it needs to observe. It can be decremental, but the A and V should be linked, should be associated, right?
Yes.
You can,
Yes.
yeah. Those circles, do they speak for Maheim if there's that perturbation?
التغيرات في السايكلز يا إيمان. The changes في
So
السايكل.
that's not a Maheim behavior,
Yeah.
right?
Yeah.
It's
Not
not a
decremental.
Maheim.
Yes. Not decremental.
Oh, no. I said it can decrement. You can't tell. Well, you can't say decrement because you haven't
Linking
seen
V
the
and
increasing pacing cycle length. We've just noted something that there's a V and A relationship in terms of timing is not the same.
Yes.
And Maheim is an accelerated pathway, right? There must be VA linking. I'm using that term very loosely. So those two cycles, do they speak for Maheim? Yes or no? The answer is no.
No.
Yeah. So Egypt seems different. We don't see lots of Mahaims. If it was a Maheim, which one? Okay, now let's forget about that. Any questions? Anyone? Ashley, Prof, anyone else?
It was, the Maheim suggestion was a reasonable one from if you just look at the surface 12-lead ECG, because it has a sort of like a left bundle, left axis. But what would be against a Maheim would be I sometimes look at the RV activation. So you've got an RV right at the bottom of your page there. Usually with the Maheim, that RV is activated earlier than the HIS because you're getting activation in the distal right bundle. So you get activation of the right ventricle before the retrograde HIS. So that would also be against the Maheim, and the VA dissociation in terms of the VA time would be unusual. So yeah, I mean, I would approach this tracing, Brian. I mean, on the right, look at what I think is easier to interpret, which is the right-hand side of the page, and then work what's going on. Because the difficult thing is what's happening at the beginning.
Yes,
so
that's
sort of I would
I
see
think
it.
also Prof. Mervat mentioned that. That's a very good point that you and Prof. Mervat has made. So this is not a Maheim or doesn't behave like a Maheim. But also, like Ashley said, it depends where it inserts. Is it atrioventricular or atriofascicular, right? And besides this change in V and A, we've also seen a change in V and H, right? So those two speak against Maheim, to me. Okay, can you just adopt what Ashley has said and Prof. Mervat, Samir?
Iman.
Iman,
Explain
sorry.
the
Yes.
narrow complex
Iman,
part.
what do you think is happening on the right part of the EGMs?
Narrow part.
It's now complex tachycardia with short VA timing, and the HIS preceded the earliest HIS on HIS.
In the earliest A on the HIS catheter, not the earliest HIS على HIS. Okay?
Yes, the earliest A on the HIS catheter. Yes.
Yes. So, and this looks like eccentric or concentric activation.
The concentric activation.
So, what is the diagnosis of the narrow part? Most probably.
So it could be even RT.
Yes. Could it be AVRT? Highly unlikely because the VA time
Very short.
is
Very short.
right?
No.
Could it be atrial tachycardia? Yes.
With one-to-one conduction, yes.
Yeah, could be. But AVNRT should be high on your list, right?
Yes, high. Even RT high, yes.
Okay. Any consultant, do I move or do you have any questions for me?
So what is the final diagnosis, Brian?
It's coming. So what is this? repeated observation. We said
Termination.
RT or AT. This is just
Yes,
observation. Huh?
it's concentric.
لا mode of
Concentric.
termination.
Mode of
Termination.
termination terminated by A wave
Mhm.
on high right atrium, not followed by
So
B.
is this
And then
AVNRT? Is this AVNRT or AT of the two that we said on the narrow part?
that's exclude atrial tachycardia.
Thank you very much.
Then we
So-
have here
So
this is fast pathways and slow pathway. Yes.
yeah, this is not a
Yes.
correct answer. These are my thoughts, right? Because
Yes.
now we asked for cycle length. There was this 410, 430, 410, 430, and here it's big.
490.
Look at the A's. The A's don't change.
Yeah.
They remain
Yes.
410.
Yes.
To be honest, I did this case 2023. I should have put in AA here, but probably wouldn't have changed much, but I don't know. So I was
like if there is a jump
so
here.
what's striking for me is that the AA during the wide complex and when it changed, and probably here, didn't change, right?
Yes, didn't change.
So it means if this is correct, the A's and the V's are not driving each other, or they are not associated, or there's an intermittent association.
Yes. Yes.
I'm still yeah. So I'm thinking to myself, this is the first thing. So the blue, I'm colorblind, but I think this is blue. I'm thinking there's a VA conduction. Now I'm not saying VA, I'm thinking VA, and then when that A gets up, then it comes down. Does it get conducted during the wide complex to change this wide complex tachycardia or not? I don't know. I think we established that this is AVNRT, slow, fast, fast. Iman has been on the floor for long. Iman, I need another fellow to jump in, please. Now, what's happening here? Are the A's and the V's associated, intermittent association? Someone else other than Iman. She's given a lot. I've got 18 minutes. I'll wrap it up soon. Anyone else?
But in that case,
Hi, Brian. It's MC here. Yes, when I look at it looks like there is association between the V and the A. When I look at the left side of this, that's the left side of the screen is the tachycardia. From what I can see, the wide complex tachycardia. I'm just trying to. I'm not sure if I'm missing something. I don't know how there wouldn't be when each of them, each V is followed by an A, each V is followed by an A.
But how do you know it's followed by A? You must be careful by being followed, or you can just say AV association with, because how do you know that A is not going to that V? Don't follow me now. So I've gone through the training.
Okay.
This is me now, but you have to answer your own way. Don't be fooled by my assessment of the slide. Just be careful. So you describe what you see. So what I'm asking, how do you know that this V goes to that A?
I can't be sure, to be honest.
You cannot be.
I can't be sure. Yeah.
My issue here during the wide complex tachycardia is that AA remained the same, but V was alternating. So to be honest, I don't know. I was beginning to think that maybe there's a dissociation. I will go to the next slide in the interest of time, but is there anyone else who wants to say something before? So MC, let me put you on a spot. What do you think is happening on the left side of the screen? VT, pre-excitation, aberrancy, because we haven't heard your voice. What's going on, wide complex tachycardia?
Yeah, so when I look at this, I see that there is activation. The first signal is, it looks like it's both the HIS and the RV. The very first V that I see here, they come at about the same time. So I would think that this would be a retrograde. This would be retrograde from the V to the HIS, and not an accessory pathway. But I wouldn't call it a VT. Maybe an accessory pathway along the conduction system, or somewhere septally, is what I would think.
Okay, we've discussed this. So accessory pathways are very stable, right? So why in this EGM, his EGM, this HIS is very different from the first four? So I've already said this is can you, except for a few of the Maheim-like, can you get the dissociation when you've got a bypass tract, excluding one rare or two rare accessory pathway, except in Egypt, of course? I thought someone was going to laugh. Ashley.
I am not sure, Brian.
Yeah.
Sorry.
So Brian, I mean, can I chip in a bit?
Yes, please.
Okay. All right. So to me, you need to see the numbers, which is what you've shown here, right? Because just eyeballing it, you can't be sure. So you've got a tachycardia, which the A to A intervals are constant at 410. All right. That's throughout, presumably. All right. You've shown that the curious complex is the wide complex tachycardia varies in rate. All right, but without changing the A to A intervals. So to me, that tells me that the V is not part of the circuit. The A's, you've got a situation where the ventricles cannot be part of the circuit. So it essentially excludes, an AVRT. You've got you've got probably a dual tachycardia. You've got an AV nodal reentry running throughout, and you've got the only way you can explain it is that you've got a ventricular dual tachycardia with maybe a VT running at slightly different rate, but pretty close to the AV NRT rate. That would be the most logical explanation, because you've got the A's that are continuing at the same cycle length. You've dissociated V from A. So we know that the underlying tachycardia doesn't involve the V, which is the AV-NRT. And the only way you can explain the change in the V to V intervals is with a dual tachycardia, like a VT.
Okay.
There is the remaining possibility. It could be atrial tachycardia with double firing, one on fast pathway and one on slow pathway.
Hold on, Iman. This is now not a theory. We've already proven that the narrow complex tachycardia is AV-NRT. So let's not add something else. So this is not AT, right? You can see on the slide, right? This was a repeated observation.
It could be double firing. Double firing. One atrial beat on the slow pathway and one atrial beat on the fast pathway. So it ended with A wave.
I'm a bit confused. Are you saying this narrow complex tachycardia, it could be something else other than AV-NRT?
No.
You just said here something like atrial.
AV-NRT, yes.
Okay,
yes,
for the
yes.
simplicity, yeah.
Yes.
The narrow complex tachycardia, I think it's AV-NRT, or we know it's AV-NRT. Ashley just described it so eloquently at this point in time.
Yes. Yes.
I'll come back to him.
I'm
But
telling you another differential diagnosis. Yeah. Discussing another possibilities.
What's the other possibility?
Other differential diagnosis. Yeah.
What is it? What is the other differential?
Okay. Okay.
Okay, let's take what Prof. China said. Do you have any other potential? It can be. That what he said is not final. Okay, let's leave it at that. But this is not, guys, this bypass tract, remember, observe the rules of bypass tract, that the A and V are associated. So let's forget about the Maheim for now. And assuming that's not Maheim. So, what will you do now? So we know the second part of the tachycardia is AVNRT, the wide complex tachycardia. So you've got a wide complex tachycardia. You think it could be SVT going through, or could be just VT. What would you do? What maneuvers, what diagnostic maneuvers would you do in a wide complex tachycardia? Usually, I'll give you a clue, in a narrow complex tachycardia, we pace the V, ventricular overdrive, and see the response. What would you do in a wide complex tachycardia?
Atrial pacing.
Not Iman,
CS.
someone else. Iman, you've been great, but there are other fellows. Please speak up. Wide complex tachycardia, what will you do?
Dr. Balata from Germany.
I may try to atrial pacing, also high atrial pacing.
Yes, what kind of atrial pacing? Overdrive pacing?
Overdrive pacing.
Is synchronous PACs, any PAC?
I will go for CS pacing, proximal pacing.
No, that's not.
Overdrive pacing.
Okay, yeah, it's atrial, whether it's CS or most of us will do the high right atrium. Is it going to be his extrasystoles, his synchronous extrasystoles, like you will do his synchronous PVCs, or will be the atrial overdrive pacing? Okay, I'm going to give you, so you can either do his synchronous PAC or any PAC in a wide complex tachycardia. And let's assume it's bypass tract. What can it do? Because we've seen, you guys mention it. What will it show?
Is what
PAC if there was an accessory pathway? Because you guys keep going to accessory pathway. What will it?
Also A will will come earlier. A will advance.
No, you're pacing A now. So you're pacing A. What's the next thing that you observe? Let's sticking with his synchronous PACs. Yeah. What you may observe, assuming you capture.
I don't know.
It will differentiate if it's nodal conduction or septal accessory vascular.
So will there be a nodal conduction if it's his synchronous PAC? The answer is no.
Yes,
right?
His synchronous PVC, yes.
No, we're doing PAC, not PVCs. Okay, so it can't go down the nodal route. So if there's a bypass tract, what will happen to the V, both cycle length and morphology? What happens if it's his synchronous PACs and the QRS doesn't change, but is advanced or delayed? Let me say that again. What will happen to the QRS cycle length, delayed or advanced, and morphology? Two questions. If there's a bypass tract.
If there's a bypass tract, it will advance.
It may advance depending on the conduction properties, right? Yes. What will happen to the morphology of the QRS?
It will change in morphology.
it will change morphology. Why would it change morphology if it's pre-excited?
Because of the fusion.
Antidromic, because antidromic, it means that the V on that side is
Very
fully
excited. Yes.
excited,
Very
right?
excited. Wider.
So how can you more fully excited?
Yes.
If there's a word like that.
Yeah.
And we may have a variable degrees of fusion, and then we will have a wider one when it becomes fully pre-excited.
It's pre-excited and it's going down the accessory pathway, up the AV node or up the other accessory pathway. So generally, the morphology won't change. Ashley, is that true?
Yeah, that's true, because a pre-excited, it's an antidromic, goes over an accessory pathway up the AV node. That's already fully pre-excited. So when you give a HIS or an AV node refractory PAC, you'll potentially be able to advance or delay the already fully pre-excited V. So you wouldn't expect a morphology change, but you
Yes,
could
that's
reset the
correct.
tachycardia. Yeah.
Yes, guys. So that's very important. Because if it's fused or gets narrower, what does it point to? Probably there's a bypass. That's a it's a VT with a bystander, right? If it's his synchronous, because it can't go down the AV node. If there's a bystander, it might change it. If it's a bystander, so the first one was antidromic, which is part of the circuit. That's what Ashley and I were describing. If there's a bystander, it might change the morphology. Because now you can't go down the AV node. But anyway, what will happen is VT, what's going on here? So we're doing now AOD, atrial overdrive pacing. What do you see? I will tell you, I don't have the numbers, but you can see on the right side, it's still that left bundle-like. And on the left side, when we're pacing the A, the QRS is no longer wide, right? So this is probably not pre-excited, right?
Right.
Yeah, so what's the response to this? Assuming that we captured and we got the RR interval to the pacing cycle length. What do you see? This is the last A we captured. This is a V.
Ventricular.
This is V.
V, right.
And that's A. So VAAV. So what is this?
Atrial?
Yes.
The answer is written.
Yes. VT.
Anyone else other than Iman, please? Mawat, Rafat.
Marwan Refat. This is a consultant of electrophysiology in Lebanon. Marwan Refat.
Oh, no, I don't want a consultant. I want fellows.
Okay, if you need fellows, we have Hasib Raza. Hasib from Pakistan.
Okay. This is the VT, guys. There's there's an AVVA response. I had difficulty in ablating it. Started on the so VT ablation will terminate on the LV septal. Don't ask me why I started on the LV septal. And when I went to the right side, it terminated, right? So this is a summary of a patient. And Ashley got it proper. So this white complex is VT, the narrow complex is AVNRT. The question remains, though, that did it change? Did it change from VT with a VA conduction to AVNRT, or it was a dual tachycardia, like Prof. Chin said, AVNRT with a VT. The only problem I have with that is there's this change in atrial activation, but the most plausible, he said, you've got AVNRT doing its own thing, and you've got VT doing its own thing. So this was AVNRT plus VT in a patient with coronary disease and low EF. So that's a final diagnosis. The only thing I can't tell you is that, was it a dual tachycardia, which I think it was. I don't think it moved from VT to AVNRT. I think they were occurring at the same time. Yeah.
So what did you do with AVNRT then?
What do you think I did?
Ablated.
Yes. Why wouldn't I? And okay, since you asked that question, I use irrigated catheter like all of us. Would you change to a non-irrigated catheter for AVNRT and open a new catheter?
No.
Prof, that's not for you.
I love to answer.
No, you don't change, but we don't want to use irrigation. So you turn off your irrigation and can drip at 2. So you use the same catheter because you can't
Actually,
use.
we use 2 mm flow so that the catheter is not blocked.
Yes,
Because
that's
you
what we
might
do.
need irrigation somewhere else. But
Yeah.
I want to say, could it be AVNRT starting in the beginning, and because his cardiomyopathy and his ejection fraction 30, this drove him into VT?
I don't know.
Okay. So if I were you, I would go and ablate AVNRT first so that I have this VT alone, so that there would not be in a challenge between two running tachycardias. Like this is, they call it dual tachycardia. So I would start with the AVNRT, the easiest, get rid of it, and then concentrate with the VT.
That's what
But
I
this
did.
is, yeah.
That's what I did.
And Brian, in presentation, when he presented, before the cath lab, was his main arrhythmia AVNRT or VT?
No, we thought it was VT.
It was mainly VT. Oh,
Yes.
I see. Okay.
Yes. So we went in there to ablate ischemic VT, and we saw this.
Okay.
Yeah. So we did ablate the AVNRT first, non-irrigated, of course, and then MAP and to septal VT, or at least going through septal VT. So, but I think Ashley did a wonderful job. It's not a easy tracing for me, at least. The only question is that it's either Prof. Mervat was saying AVNRT giving us VT or dual tachycardia. I don't know which started what. I can't tell you that. All I know that we started off with a wide complex tachycardia. We would do RV pacing, and we induced this wide complex. Fortunately, we were able to see another complex tachycardia as well. Yeah. So my money is on dual AV node. Dual tachycardias.
I think so.
Yeah.
Yeah, it's almost like you're giving, the VT. The VT was actually his-refractory PVCs sequentially, and which did not change the A.
Yeah.
So we sort of like excluding an AVRT right up front, although the VA time was very short in the narrow complex, so you can kind of exclude a AVRT quite easily on the right-hand side of the page. But
The other thing, Ashley, what made me wonder about, that's why I was saying to him, see, don't follow my blue arrows, is that this VH, if you want to call it that, it's a bit too short for this V to be going up the right bundle up to the to the A. I think this H, and it looks orthodromic, it looks like it's coming from top. So to me, this is a V8 dissociation, because this V to get to that H so quickly tells me that probably this was just an evidence of fusion or concealed fusion. You cannot see it. You cannot see it. I think the AVNRT is going, this A is going down, captures the antidromic H, and the V just happened at the same time. I don't think this is V going back to that A, because that HV is just too short. And you look, sometimes you can see a change in the morphology of the H, depending whether it's captured antidromically or retrogradely. Antigradely, sorry, or retrograde. But anyway, I know my time at every minute of it, but I think that was a case that was nice for me.
That was it. No, thanks, Brian. That was a very useful. What I would measure is that HH intervals backwards, and just see if that HH falls on time, moving backwards, then it's probably orthodromic S capture from the AVNRT.
Oh no, definitely this HH were the same.
Yes, so that is orthodromic S capture from the AVNRT.
Yes. Yeah.
That is, yeah. Okay. It's 6:05. I think everybody's stunned now from this beautiful case, Brian. But thanks very much for this very interactive, very nice interactive learning case. I'm sure all of us learned a lot from the case as well, and I'm sure our fellows and consultants have as well. So thanks again. And Prof. Mervat, you just want to have the final words?
Yes, it was an interesting case with a lot of discussion with the fellows, and I appreciate this case very much, Brian, because first of course we have to learn about taking a very good attention to the signals and to the sequence of the signals, even in different beats. This can help you to reach the diagnosis. Also, placing the his catheter in stable position also opened the diagnosis of these two tachycardias competing between one another. So please, for all fellows, because we are teaching them, the placement of the catheter, the signals, the very clear 12-lead ECG, or not 12-lead, the V1 and the limb leads should be clear, and especially V1, because V1 opened the discussion to the left bundle branch block tachycardia. I know that Brian is very intelligent, and he hid the diagnosis, which is a cardiomyopathy, the ejection fraction 30%, so that will not jump to the diagnosis of VT.
I didn't want that.
I knew that. So before you start to bring any patient to the lab, you have to look at the history, the echo finding, the clinical tachycardia, his resting ECG, in order to put all these side by side in order to reach final diagnosis. That was an excellent discussion, Brian, with the interrogation and the discussion. And I was confused in the beginning. I thought this is Mahayam, and this is bystander Mahayam, and this is AVNRT. But you proved to me by step that this is not what I thought. Thank you, Brian. Thank you, Ashley, for your time. Thank you very much.
Thanks, everyone.
Thanks, everyone.